Hello dear students, in this video we will study type 2 diabetes and its treatment. In type 2 diabetes, the pancreas retains some beta cell function, but variable insulin secretion is insufficient to maintain glucose homeostasis, and it is frequently accompanied by the lack of sensitivity of target organs to either exogenous or endogenous insulin. So this resistance to insulin is considered to be a major cause of this type 2 diabetes. Also, type 2 diabetes are influenced by genetic factors, aging, and obesity. As type 1 diabetes, the goal to treat type 2 diabetes is to maintain blood glucose concentration within normal limits and to prevent the development of long-term complications. Weight reduction, exercise, and dietary modifications decrease the insulin resistance in some patients and correct hyperglycemia. However, most patients are dependent on pharmacological intervention with usually oral glucose-lowering agents. As the disease progresses, beta cell function also declines, and some patients may require insulin. Now, let us talk about the oral agents that are used to treat type 2 diabetes. The first group are the insulin secretagogues, which contain the sulfonylureas and the Biguanides. These drugs are classified as insulin secretagogues because they promote the insulin release from the beta cells of the pancreas by blocking the ATP-sensitive potassium channels, resulting in depolarization and calcium influx. They also reduce hepatic glucose production and they increase the peripheral insulin sensitivity. Drugs in the sulfonylureas group are glyburide, glipizide, and glimepiride, while Biguanides are ribaglinide and natilinide. Biguanides bind to a distant site on the sulfonylurea receptor of the ATP-sensitive potassium channels, thereby initiating a series of reactions which will also result in the release of insulin. These drugs are usually used in combination with other drugs, the other groups that I will mention them later. The second group of oral agents is the insulin sensitizers, which are the Biguanides and Thiazolidinediones. These agents lower blood sugar by improving the target cell response to insulin, thereby decreasing the insulin resistance. For the Biguanides, metformin is the only current available biguanide. Metformin reduces hepatic glucose output largely by inhibiting gluconeogenesis. It also slows intestinal absorption of sugars and it improves the peripheral glucose uptake and utilization. Metformin also reduces hyperlipidemia. The American Diabetes Association recommends metformin as the drug of choice for newly diagnosed type 2 diabetes. This drug also can be used alone or in combination with one of the other agents. Another group of agents that are also insulin sensitizers are thiazolidinediones, also called glitazones. The two members in this group are the pioglitazone and rosiglitazone. These drugs target the peroxysamine proliferator activated receptor, which especially the gamma, which we abbreviate them as PAPA gamma. And this PAPA gamma is a nuclear hormone receptor. By activating this receptor, they regulate the adipocyte production and secretion of fatty acids as well as glucose metabolism, resulting in increased insulin sensitivity in adipose tissues, liver, and also skeletal muscles. The American Diabetes Association again recommends pioglitazone as an alternative for patients who fail or have contraindication to the metformin therapy. The third group of oral agents is the alpha-glucosidase inhibitors, Acarbose and Miglitol. These drugs show their effects by reversibly inhibiting membrane-bound alpha-glucosidase in the intestinal brush border, which is responsible for the hydrolysis of oligosaccharides to glucose and other sugars. These drugs are recommended to be taken at the beginning of the meal so that they delay the digestion of carbohydrates, thereby resulting in lower postprandial glucose levels. The fourth group of oral agents is DIPEPTIDYL peptidase-IV inhibitors, Sitagliptin and Sitagliptin. The mechanism of action of these drugs is that they inhibit the enzyme DPP-4, which is the dipeptidyl peptidase-IV, which is responsible for the inactivation of incretin hormones such as glucagon-like peptide GLB1, and prolonging the activity of incretin hormones results in increased insulin release in response to meals and a reduction in an inappropriate secretion of glucagon. Again, these drugs, they can be used as monotherapy or in combination with other drugs in the other groups. The last group of oral agents are the incretin mimetics, which are exenatide and liraglutide. These drugs are analogs of glucagon-like peptide 1, and they show their activity by acting as GLB1 receptor agonists. These drugs, they not only improve glucose-dependent insulin secretion, but also slows gastric emptying time, decrease food intake, also they decrease postprandial glucagon secretion, and promote beta cell proliferation. All of these effects will lead to decrease in weight gain and postprandial hyperglycemia. Thank you for watching. Please don't forget to subscribe to this channel.